Welcome, and welcome to Listen to Your Body, the second installment of Listening to Your Body. What the Baltimore community needs to know about a hereditary disease that is in hidden plain sight, hereditary transthyretin amyloidosis. I'll be your host this evening. My name is Wayne Pulliam. I'm the CEO of Woods Adult Day Services. I will have Dr. Jannae White, who's our heart failure specialist from Ascension St. Agnes Hospital, and Ms. Velma Henderson, RN, former chief nursing officer, who's going to bring a lot of insight to the fact because she has gone through this personally with her own family. So again, don't leave before you hear her. It's a very, very powerful statement. She's going to talk about a disease. And the reason we're doing this, because it is an undiagnosed disease that is affecting communities all across the United States. A lot of times it's fooled as congestive heart failure or carpal tunnel, which has a longer life expectancy. With hATTR, the life expectancy is much shorter. So it's very important that we identify these patients very quickly. So I'd like to thank, first of all, AstraZeneca for helping us put this event on tonight, as well as my company, Woods Adult Day Services. And of course, we couldn't do it without Career Communications, with being able to broadcast this across the United States. Also, of course, I'd like to thank Dr. Jannae White and Ms. Velma Henderson for their participation today. Welcome to Listen to Your Body, and I mean listen to it today. There's a lot of valuable information that's going to come out tonight. It's a presentation about hereditary transthyretin amyloidosis, or hATTR. The disease can be tough to diagnose as it is a symptom often looks like others, more common health issues, or what we may think as a sign of just plain old aging, but it is not. Our goal today is help you understand the signs and know when to talk to a doctor and learn about the steps you can take if you think you are a loved one that may have hATTR. Well, we'll discuss who may be at risk, the many different symptoms, the test doctors use to confirm hATTR, what treatment options are available once someone is diagnosed, and what to do if you think that you or someone may have the disease. So that's kind of get you warmed up, kind of where we're going. Before we get any further, I want to make it clear about questions. A lot of times you have a question, we sit here and we hold the question until the end and you don't pay attention to the program because you want to make sure you get your question in. So the main thing is, if you have a question, please raise your hand. We have someone to go around with the mic, so don't hold it to the end. You have a pertinent question that may answer and usually it answers somebody else's question in the room when you ask a question, that please don't hesitate to ask your questions. Without further ado, I'd like to bring on a very interesting speaker. I think you're going to find her very captivating, and she's one of our own right here in Maryland, St. Agnes, is Dr. Jannae White. And she'll be our first speaker tonight. Dr. White.
Thank you. Thank you so much. And thank you so much, Mr. Wayne Pulliam. I appreciate you having us here tonight and getting to present on this very important topic and being up on stage with Velma Henderson as well. It's always a pleasure. So what are we going to talk about today? And I think that we'll advance our slide up here as well. Perfect. So we'll do an introduction to ATTR and hereditary amyloidosis. So you're going to hear me use a lot of abbreviations during our talk today. I might say ATTR, and that stands for transthyretin amyloidosis. And then you also might hear me say hATTR, which stands for hereditary amyloidosis. So we'll talk about what this is, what's the difference between hereditary and wild type. We'll talk about the importance of knowing family history and why those health conditions, knowing specifically those health conditions, is so important. How ATTR affects different parts of the body, as well as symptoms, how we diagnose it, and how to have discussions with your healthcare provider concerning the symptoms that you're experiencing. That's so important. You know your body better than anyone else. You live in your body 24/7 for however many years. As your healthcare provider, we are here to work along with you based on our expertise to help figure out what's going on and how to address things. And then finally, we'll have a call to action. You can go to the next slide. So let's go over what is transthyretin cardiac amyloidosis. So TTR, and I'm going to stand up here a little bit so I can move around. So TTR, transthyretin, is a protein that's made in the liver, and it's a transporter for different substances around the body. So thyroxine and retinol or vitamin A, it's like a semi truck that transports it from place to place around the body. In people with transthyretin amyloidosis, this protein, which typically looks like a four-leaf clover, becomes misfolded and then gets deposited in different areas of the body. If it's deposited in different areas in the body, it's not doing its job transporting thyroxine and vitamin A around the body. Depending on where it gets deposited, it can cause a bunch of different issues. So some of those include, and you can see on our little diagram here, it can cause eye issues such as glaucoma, can cause ruptured and torn tendons that either affect the bicep or the ankle or heel, the Achilles tendon area. Sometimes it can cause stomach or gut issues such as constipation, feeling sick or nauseous, as well as getting full quickly. It can cause pain or numbness in the lower back, the legs, shortness of breath, pain or tingling in the wrists and the hands, which we call carpal tunnel syndrome. It can cause joint pain, hip or knee pain, and it can cause some numbness and tingling in the toes and feet. So you may experience one or several of these symptoms. It doesn't necessarily mean that you have transthyretin cardiac amyloidosis, but it's important to be aware of these symptoms to start that conversation with your medical provider as well, so we can figure out what's going on and how to best manage it. All right, next slide. Okay, so there are two different types of ATTR. So it can be inherited, or we can have the wild type. So TTR that's inherited is called hereditary, or hATTR, and hereditary is just passed along in families. So grandmother to the mother to the child, just passed along in families. And importantly, not all of the people with hTTR, the gene passed along, are going to have symptoms. So that's important to know. Also importantly, specifically with hereditary ATTR, many of the individuals are of African descent, and we'll talk a little bit more about why that is. You can have symptoms of amyloidosis starting in the 50s, in your 50s and 60s. Importantly, wild type amyloidosis is mostly seen in older adults, but we're learning more. It used to be called senile transthyretin amyloidosis, but again, as time goes on, we're learning more about wild type, and it can be found earlier as well. This population that we know right now is primarily older white males, but again, things are changing as we test more and look more, we find more. So today, we're going to talk a little bit about both wild type, not inherited, and then hereditary, passed along through families. We can go to the next slide. So 3 to 4 out of every 100 African Americans in the United States carry the gene mutation that's often linked to hereditary amyloidosis, the V122I mutation. Carrying this mutation, again, does not mean that you will necessarily develop the disease, but it is important to know because that risk is there. So having parents or older relatives with symptoms of hATTR is important, but again, it just means that you need to be having a close relationship and conversations with your healthcare provider so we can be monitoring how you do. And if you do develop symptoms, start treating early. But again, does not necessarily mean that you will develop symptoms. Knowing your family history is very important. You would be surprised how many patients come into my office and I ask them, does anybody in your family have heart failure or any other cardiac illnesses? And they often say to me, I don't know. We don't talk about that. So it's important to have those conversations to help each other out. Okay. All right, so how hATTR affects the body. We'll go over some of these common symptoms that are caused by amyloid deposits that cause damage to different organs that they're deposited in and different nerves as well throughout the body. You can go to the next slide. So ATTR can be challenging to diagnose because many of the symptoms that we discussed earlier, joint pain, numbness and tingling in the hands and wrists, numbness and tingling in the legs or feet, gut issues, constipation, nausea, many of them can be caused by other things as well, shortness of breath. So it gets a little tricky to diagnose, and that's why it's so important to work with your healthcare providers as well. Because of this, though, and very interestingly, I know I keep saying work with your healthcare providers. I think that Velma can attest to this as well. Sometimes when we work with our healthcare providers, even then, it takes a while to get diagnosed. And we hear that more and more. We're working on continuing to grow education within the healthcare community so then we can find cardiac amyloidosis earlier to begin treatment. But I think it's on average that patients see about 5 healthcare providers, something like that, before they're accurately diagnosed with transthyretin cardiac amyloidosis. So that should improve, but we're out here spreading awareness for that reason, for the general public, and as well in the medical community space, we're doing the same thing. So symptoms often occur at different times and then get worse as cardiac amyloidosis progresses. You can go to the next slide. All right, so first we'll look at amyloid damage to the nerves throughout the body called ATTR peripheral neuropathy. And so those are some of the symptoms that we discussed a little bit earlier, the numbness and tingling or pain in the hands and feet, and that often can progress to muscle weakness. You'll hear that termed or called peripheral neuropathy. That's what you'll hear your medical providers say. And then as well, severe back pain, loss of muscle, heaviness in legs, muscle tears. All of these are some of the musculoskeletal symptoms of amyloidosis. Go to the next slide. And then you have, again, talking a little bit more about the damage to the nerves throughout the body. The numbness, tingling, and burning in the fingers in particular, that's called carpal tunnel syndrome. We often see it bilaterally, and they're frequent early symptoms of hATTR. They often affect the non-dominant hand first, and then again can progress to weakness gripping objects. We can go to the next slide. Oftentimes when I'm seeing a patient, I'll look for these diagnoses that they've had. I'll look to see, do they have a history of carpal tunnel syndrome, and did they have a procedure to help with that maybe when I'm assessing what's going on with the patient. So as related to nerve damage throughout the body, it can also affect the gastrointestinal tract. That's the stomach and the intestines. So significant and unexplained weight loss, which is called unintentional weight loss. I know we all get really excited about weight loss, but unintentional weight loss, if we're not dieting, if we're not exercising anymore, and our weight is just dropping, we have to think to ourselves, what is going on? So don't just celebrate it, also kind of take a second to think what's going on. So symptoms related to the gastrointestinal manifestations include nausea, vomiting, diarrhea, and constipation, which can be very common symptoms that people have. So again, we have to put the pieces of the puzzle together. All right, we can go to the next slide. There can also be decreased sexual function or other problems controlling the bowels and the bladder. Again, this is so interesting because it's all related to the nerves and how when there's damage to the nerves, it can cause these different problems to different body systems. So you can have digestive issues such as chronic diarrhea or constipation or going back and forth between the two, loss of bladder control or difficulty urinating. And then as for the gentleman, difficulty getting an erection. So if you're noticing these things, again, make sure you include them in your conversation with your medical provider. Next slide. And then we can have kidney problems as well. So I often work, and I think that my nephrologists on my team are actually pretty good. Those are the kidney specialists. They do a good job of kind of assessing as well for amyloidosis, just as kind of a very general workup when they first see patients as well. Because it can cause kidney problems. Amyloid deposits in the kidney can cause kidney dysfunction. We can see things such as proteinuria when we do urine tests, which is too much protein in the urine. We can see that kidney damage can cause symptoms of frequent urination, shortness of breath when you start holding on to extra fluid, muscle cramping at night, particularly when there's volume or electrolyte abnormalities, and then as well, nausea, vomiting, and loss of appetite. Go to the next slide. And then heart problems. So this is when I see patients. This is when they end up coming to me. So those deposits in the heart muscle can lead to many different symptoms. Swelling in the legs, ankles, and feet, feeling dizzy and lightheaded when first standing up. So it's not uncommon for some individuals, depending on different other conditions that they have, to get some brief dizziness and lightheadedness when jumping up too quickly. But when we start noticing this significantly, again, we have to look at it as one of those pieces of the puzzle and start putting it together. We'll test their blood pressure sitting and then standing as well. And sometimes we'll see a big difference, which we call orthostatic hypotension. Many people with hereditary cardiomyopathy or ATTR also experience the symptoms that we spoke about earlier, those musculoskeletal nervous system symptoms as well. Go to our next slide. And then I know this is tough, but we can see excessive tiredness and fatigue. And sometimes that's such a difficult symptom to pinpoint and narrow down the cause, because so many people experience fatigue and tiredness. But as a piece of the rest of this puzzle, we can put it together. Shortness of breath, reduced ability to be physically active. So yesterday or last week, let's say, I was able to climb up the steps without stopping, but this week I'm more short of breath climbing up the steps. And then a month from now, I have to stop halfway up the steps. You know, those changes are important to notice and then discuss with your healthcare provider. We can also see irregular heartbeats, arrhythmias. One common one is atrial fibrillation that you'll hear quite a bit of. Next slide. And then eye problems, glaucoma, cloudiness of the eye, and then vitreous opacities as well. So your eye specialist, you know, may notice some of these things when they're doing their regular exams. And again, when I see them as someone's past medical history or some of their medical history, it's again another piece of the puzzle that I put together, and it makes me question. All right, next slide. So before I jump into how hATTR is diagnosed, I just wanted to stop really quick and assess, do we have any questions, anything that I haven't explained well? I'm happy to try and explain in a different way. If not, we'll keep moving right along. If you do have a question, like Mr. Pulliam said, please just raise your hand and we'll get to you. So how is hATTR and ATTR diagnosed? So typically it's going to be through a specialist like a neurologist or a cardiologist. Again, I think that with building awareness among healthcare providers, this may change over time, but right now it's typically going to be a specialist that ends up diagnosing you. We have different tests included in our diagnosis. Some of those tests include genetic testing to differentiate between wild type and hereditary type. Some of those include a tissue biopsy. In some cases, not as many cases as used to be needed for diagnosis. Bone scintigraphy, which is like a PYP scan, and we'll talk a little bit more about that, a non-invasive test to scan. Electrocardiograms, where they put the stickers on your chest and they're able to get the read of the electrical conduction through the heart. Echocardiogram, which is an ultrasound, so similar to pregnant ladies, they put the gel and then use an ultrasound wand to check the heart's pumping function. You have well as a PET scan, cardiac PET scan. And then for the neuropathic, to assess kind of the neuropathic damage, you have the nerve conduction studies as well. Okay, next slide. And then we'll jump into how hATTR is treated. This is actually really exciting because a lot has changed over the past several years. So initially, when I first started in cardiology, even though I was in the heart failure space, this really wasn't something that we looked for a ton. We had to kind of be really suspicious to look for it. And really the primary reason, if you ask me, was that there wasn't really any treatment options on the market. So we didn't really look for it. There weren't any management strategies on the market. And then we started coming out with some medications that could help. And so we started looking for it because we now have a medication that can make a difference for individuals' quality of life and quantity of life. And now we're learning so much more, finding so much more about cardiac amyloidosis. We have multiple drugs coming on the market that are going through testing that can really help people to feel better and live longer, which is a really, really interesting thing to see. So right now we have two different, thank you so much, I appreciate it. So two different FDA approved medications forms on the market, one of them coming onto the market for cardiac indication. So we have the gene silencers and then the gene stabilizers. So again, that transthyretin is like a 4-leaf clover, and we don't want it to get folded up, because when it gets folded up, misfolded, that's when it gets implanted or deposited in different areas of the body and causes trouble. So we have a couple of different options, but these two primary options are: one, reduce the amount or stop the production of TTR, and the other option is to stabilize it, so then it keeps its form as a 4-leaf clover and just operates as a semi-truck transporting the substances that it's supposed to transport. So you can either stop the production with a gene silencer, or with a stabilizer, prevent the protein from folding up and getting deposited where it should not be. All right, we can go to the next slide. Absolutely. All right. So I'm going to pass it back to Mr. Pulliam here, and it looks like we are going to talk. Oh,
we have a question. Yes. Question.
Okay, so I have a question. So I'm a cardiac patient, and I originally came here with like this whole about linkage of services and the doctors and nurse practitioners listen to us. But now I'm just gonna dump all that because you totally shifted. So I have every single symptom, and I've been going back and forth. Because all of a sudden, this summer with the whole good and just every single symptom. So how do we get everyone to kind of listen? And then on the medication, does it alleviate some of these symptoms? Because I'm a teacher. I go up the stairs quite a bit. Yeah. Some days it's great. And then you like you said, some days I'm like, whoa, I got to stop. And I'm high energy. Some days when I go to the gym, it's great. And some days I'm like, I just got to go home. This is not working. So how do we eliminate all of this? And because I have a cardiologist and no one's discussed this with me, they can't even tell me for sure if I have congestive heart failure or not. So I take furosemide, and now I'm kind of like, should I even be taking furosemide? And I brought that up in my visit because I was like, do I need spirulactin instead? Because, furosemide takes so much out of you. So I'm like, maybe I didn't even need, after hearing this, I'm like, maybe I don't even need the furosemide. Maybe something else is going on.
Sure.
So how do we get there?
Yeah, that's a great question. So afterwards, we can kind of talk a little bit more specifically, but I'm going to kind of answer a couple of things that I heard in there a little bit more generally. So one, it is really important to have a trusting relationship with your healthcare provider, one in which you feel listened to and heard, so that's very important. I think that sometimes as well, I know that sometimes I have patients that come into my office and say, Jannae, I'm concerned about this. I'd like to talk about whether or not I have this condition, cardiac amyloidosis. And as a healthcare provider, it's my job with my expertise to say, let's take a look at your chart. Let's talk about what's going on from a symptom standpoint, and then talk to you about this is why I don't think this is something that you have, or hey, let's investigate this a little bit further. If after all of that you really don't feel like anything is happening in a satisfactory way, or at least you don't feel like you have a good understanding of the plan of care, then I would encourage you to seek out a different medical provider. I think that can sometimes be helpful to have just another look, another eye, over things. And then, sure, absolutely. And then I'm also going to let Velma speak to this a little bit more because she has a lot of personal experience.
I wanted to say, don't stop taking furosemide.
Sure.
Because, yeah, okay, right. Because even if you end up with the diagnosis of hATTR, usually that is one of the things that we use to keep the symptoms.
Yeah.
Because you still have heart failure. It's just we know it's caused by something different. So don't stop taking it.
Yes, I think that's an excellent point. And from a medication standpoint as well, yes, there's certain medications that help with kind of managing the TTR deposits, which is what I was talking about a little bit earlier. And for the most part, the medications on the market right now slow down the progression of cardiac amyloidosis, okay? Now, again, we have some exciting things that are in clinical trials right now, so we'll see what's to come in the next couple of years. But to address symptoms, just like Velma was saying, we use other medications to help address some of the other symptoms that individuals may have. Yeah. So, but these medications that I was discussing right here focus on slowing down the progression of cardiac amyloidosis. Yeah. So it's a combination.
We appreciate the question because I know this topic is anytime you don't know, it gets a little scary when you hear about something that's being misdiagnosed. So to break the monotony, I'm going to sing a song for y'all for a little bit, if y'all don't mind. Everybody's going to bear with me now. I'm just joking. But again, Dr. White, thank you. That was a very heavy part of the presentation that you just did, and really appreciate for information that you brought out this morning. Without further ado, it's time for you and for you and Velma to kind of dig down and really give folks a real perspective on what it's like to live with this disease.
Yeah, so I'm so glad to be up here to talk to Velma a little bit more about what her experience has been, and I will let her go into it. But let me just start off very generally, Velma. How did you come to learn about cardiac amyloidosis?
Well, that's an interesting question because I am a registered nurse and my clinical practice was in the intensive care unit where I took care of patients who had heart attacks. Now, in the 80s and even part of the 90s, if someone had a heart attack and they made it to the hospital, things still didn't go well for them because usually basically the only thing we could do is really to just kind of treat the symptoms. But having said all of that, I had never heard of cardiac amyloidosis. We treated patients with heart failure, we treated patients with heart attacks, and that had become my passion. I served on the board for a national organization called Women Heart. And this organization was dedicated to improving the care of women with heart disease because most of the research was done with men and white men. So our goal was then we need to get more women because women are not they're not little men. You know, women are different. We have all kind of hormones that men don't have, and drugs affect us differently. So that was really a passion of mine. So it was amazing to me that I had not heard of cardiac amyloidosis. And I worked with cardiologists. I mean, I was at Howard University Hospital, and they were known for the care of black folk with heart disease. And yet, no one had ever mentioned cardiac amyloidosis until my world was rocked in 2018, and it has not been the same since. My younger brother, who was as close to me as a brother could be. I mean, we talked 3 or 4 times a day. My husband and his wife used to say the only time they found out anything was listening to us on the telephone. This is how close we were. But he was in his 50s then. This man was 6'5", professional athlete, had played basketball overseas, and he started to have all these symptoms. You know, he started to have joint pain, and then he ended up having to have hip replacement very early, and he'd say, "Well, my feet hurt," and he'd go to doctors, you know, and they'd say, "Well, you probably got early arthritis, or you got what?" Eventually, he went into kidney failure. And he is this middle when he thought he was at the stage in his life where things really should be going well. He would say, "I'm falling apart." So he went into kidney failure. His wife ended up, after years on dialysis, his wife donated a kidney to him, but his condition continued to get worse. And now he was going to a major center in Washington D.C. where they have an advanced unit, and he would go into the hospital. They'd say, "Well, you got pneumonia," because he would have trouble breathing, short of breath, and he would say, "No, I don't have pneumonia," because this topic tonight is listen to my body. He knew his body. He said, "I don't have pneumonia." I don't. He said, "I don't have no pneumonia," but they would say it's pneumonia. So finally, they said, "Well, it's actually heart failure." But then why is this early 50-year-old man going into heart failure? No one knew. It was just the fact that, well, he just got heart failure. So things just went down here from there. And eventually he got to the point that they decided to do a cardiac biopsy. And they did that and sent it to the Mayo Clinic. And the Mayo Clinic sent this back, and this was like in September of 2018. They sent a report back and said that he has hATTR-CM, which is the hereditary type that Dr. White has been talking about tonight. And they said so that has implications for his siblings and any offspring. So we would recommend that all the siblings get tested as well as any offspring that he might have. Well, this happened in September. My brother died in October. He died a few weeks after we got the diagnosis. And that changed our world because there were 9 of us originally. And of the 5 of us that got tested, there were 3 who came back carrying this defective gene. And Dr. White said you can carry the gene without getting the disease. However, all 3 of them had the disease. So that was 4 out of the 9 of us who had the disease. Now we got this information in 2018. My sister had cardiac symptoms. She had a stroke. She also mentioned to you that one of the symptoms is irregular heartbeat, which is usually atrial fibrillation. Well, all of these siblings had atrial fibrillation, and my sister had a stroke. Remember, and she was going to cardiology, now not primary care. No one mentioned cardiac amyloidosis, so I told her, "We just got this information from my brother, so now you need to take this to your cardiologist and let him know you need to be tested for this defective gene." Her cardiologist said to her, "Oh, you won't have anything like that." That's what he said. He dismissed it. So I said, "Well, then you have to go somewhere else." And she did. She went to another center. They tested her. She not only was carrying the gene, but she had cardiac amyloidosis late stage. She lived less than a year after she was diagnosed. That was the second sister. Now, third sister, and all of these siblings that I'm talking about were younger than me. Now, I'm not that young, but they were younger than me. So this was just, it rocked my entire world. So this third sister who had tested it, she had the gene. She also had cardiac amyloidosis. She also had the disease and was in heart failure. So all 3 of those siblings have died within a 3-year period. they died. And when I see these symptoms, I still feel it. I feel, my brother, when he went into kidney failure, he had no idea, why is this happening to me? And my sister, one of them had this severe nerve pain that Dr. White mentioned.
Mhm.
She would, sometimes we'd have to take her to the emergency room because she was having such severe neuropathy. The pain would be so bad. And she, why? And we didn't know why. Because no one mentioned or even thought about cardiac amyloidosis. So that was how I heard about it in the most, I think, what the most awful way, what was going through with my siblings. And remember, it's hereditary. The incidence, if a person is carrying the gene, 50% of their offspring are likely to carry the gene, as well as 50% of their siblings are likely to carry the gene. And that is the way it is in my family. Now, my brother who died had one son. He carries the gene. So for him, that's 100%. He's carrying the gene. My sister had two children. They're both carrying the gene. So that's 100% there. So it is an insidious, difficult to diagnose disease, and it's affecting the Black community and people of color in a way that's having an impact because no one knows about it. The word is still not out. I hope my answer wasn't too long. That's how I found out about cardiac amyloidosis. And remember, I was in healthcare in the intensive care unit. So what do you think is happening to lay folks when they go into a doctor's office with these symptoms?
Yeah, no, I think that you touched on so much there, Velma, that I wanted to kind of ask a little bit more about. So I'm curious to know, particularly with both of your sisters, were they given other diagnoses as well before cardiac amyloidosis was diagnosed? And I know you said 2 cardiologists for your first sister. How about for your second? How long did it take?
Until she was at the point of death, because they first the nerve pain, and then the deterioration of the joints, having to have hip replacements early, and then eventually, because the other symptoms are usually involved in the weight loss. The weight loss can be striking when you're saying to people now. There were 9 of us, and we grew up in North Carolina. No one ever had to tell us to eat. That was something like, you better watch your plate, or we're gonna take your plate. And to see these siblings losing weight because this disease is affecting their GI system and they can't eat and no one knows why. And so we would say, well, just eat. And when they said, well, I can't, and we didn't understand. So that was one of the symptoms. So they went to all, they had to have a GI doctor. And then it affects your kidney work is off. Then you got a kidney doctor and you're anemic. So then you got a hematologist and you got your cardiologist and you got primary care and you got a neurologist, because they would have trouble even walking, because it affects the nerves and they didn't know why, I can't feel my feet. So there were many, many doctors involved and it was years. And for all of them, it was really nothing that we could really do at that point, but help and support.
Do you know for the diagnosis of both of your sisters, was it an endomyocardial biopsy as well, or did they use a PYP scan?
They used the PET scan because once my brother was diagnosed, it was confirmed that he had the actual disease by biopsy. The others, it started with the genetic test, and during that time, and it sounds like it was a long time ago, but it was not. But things just have progressed. This was in 2019 when both my sisters were diagnosed, and this was after the brother died in 2018. And you had to have your blood drawn at that time to get the genetic test. Now they just do saliva, which is it's much simpler. So the first thing that they do is they do the genetic test. If that comes back that you're carrying the gene, the defective gene. Now, because remember that Dr. White talked about the fact you can have these symptoms and it doesn't have to be hATTR-CM. So you have to know for sure. So even when the genetic test comes back, that only shows that you have the defective gene. It will not show whether you have the disease or not. And then that's when you do the echocardiogram, and then the PET scan is the definitive diagnosis. When they actually get that, it's like an all-day test. They do some dye and you go and come back. and they look at their heart and how the heart is, and they can actually see the deposits of the amyloid protein, and that's the definitive diagnosis. So then, once you get a diagnosis, now when my brother was diagnosed, there was no treatment. The two types of drugs that Dr. White talked about, they were still what do you call it, clinical trials. But my sisters, both of them did take the medication. And for one of them, there probably wasn't much of an impact because she was so late in the disease. Just so many things were going on. Because it affects all the organs. What ends up, people usually end up dying from this multi-system failure. All the systems fail. My younger sister, though, started the medication earlier in her process, and she really had several years of some pretty good quality to her life because it did really delay things for her. So that's why talking about the symptoms and having people understand and people sharing and people pressing so they can get a diagnosis, it makes a difference. It makes a difference in the quality of the person's life and also even in terms of the length of life. Even though there's still no cure, but there's no cure for diabetes either. There's no cure for it. But we have treatment and we manage it. So it helps to manage. That's why it's so important that we get the word out. And I'm so thankful for the opportunity. And I appreciate this opportunity and what you all are doing in this community to try and get the word out.
Absolutely. I want to echo that early diagnosis is key. Velma's sharing an experience where her siblings were diagnosed late in the disease process. And sometimes it's really difficult to make kind of a significant change or improvement with the medications that we have right now late in the disease process. So when you find cardiac amyloidosis early in the disease process, these medications can really slow the progression. They do a great job, almost doubling lifespan, which is fantastic for a medication. And if you're not as symptomatic when you're first diagnosed, again, slowing it from that point is really helpful in improving quality of life overall. So yeah, I'm glad that you shared that a little bit about their journey with diagnosis and treatment, and you as well were a caregiver as well. Yeah, can you speak a little bit to the role on family? I guess I have two questions as related to that. One, kind of what were your thoughts when asked as a family member to get genetic testing, and then two, your role as a caregiver, what that experience was like.
Well, quite honestly, I just said I'm a healthcare professional. It was frightening for me because sometimes you don't really want to know. I'm like a lot of folks. I have a lot of denial, right? So if I really want to know, well, then I have to be the leader here. So if I'm not willing to know, then my other siblings are not going to do it either. So that was my first thought. So I have to do it, so they will do it also. And because at the time, I didn't really think that there was going to be any drugs that soon that would make a difference. However, I knew it was important because remember, it's hereditary. And even if it doesn't make a difference for my generation, it would make a difference for the younger ones. Because hopefully, my niece and my two nephews now who are carrying that gene, hopefully by the time they get to be my age, that there will be something, it won't even be an issue anymore. So I was excited about it, yet I had a little bit of trepidation.
Sure.
But you do have to face what's facing you, even though you might not feel like doing that sometimes. So I would certainly, and you mentioned about how can families and friends help?
Yeah.
Because sometimes people are afraid because they don't want to be dependent. Well, I don't want to. We can be helpful because as this disease progress, first of all, we can advise people about testing now. Testing you can get that done free. In Baltimore, you have these major centers. The only issue comes when you can get the testing free. There's a drug company that does that free. However, the things associated with that, okay, you get the test, but then they want to do an echocardiogram. You need insurance for that, or you need Medicaid, or you need something, and that's a barrier for some people because my nephew, for instance, he was in his 30s, and people in their 30s don't think they need health insurance. So he didn't have any health insurance. So there was a real delay in his getting tested because he didn't have health insurance, and they would not test him because he didn't have health insurance, even though the test was free. They said, you're not going to be able to get the follow-up. So eventually he did believe that he needed some health insurance. He did get it. And look, he does have the gene. So now he's been followed, and that's so important. Because what they do is they follow them, and if they're not symptomatic, every 5 years they do echocardiogram, checking their heart out to make sure there are no changes. And that's the best thing in the world because they're being watched. So it's important. So you can help by encouraging folks testing. When you talking to someone, and they're just like this young lady who's talking about her journey. You're talking to someone who you know some folk. There are two people in that family. They say they died of heart disease. Well, encourage them to explore that a little bit more. You cannot count on your primary care physician doing it. You can't count on it. You have to push. You have to advocate. So we can be advocates. We learn and then we share, and then we can actually help because as this disease progresses, people need help, even to take someone for a doctor's appointment, to sit there with them so you can hear what's being said because a lot of times they can't. The anxiety is so high they don't even remember what's being said. You can do that. You can take notes for them, to encourage them to take their medication. And then we talked about the GI symptoms, just the fact that to make sure someone gets a cup of soup or a bowl of soup because they don't have the energy to fix food and don't really want to eat. So simple things like that are things that we can do as friends and family members.
Yeah, thank you so much. I think there was so many important points in that story, and I appreciate you sharing it with everybody here. I just wanted to open it up before I thank Velma for sharing her story. Are there any other questions specifically for Velma and her experience?
I have a question.
Go ahead.
So could you both answer? Can you hear? Yeah. Can you both give some concrete examples when you say self-advocate? Because so many times we hear from individuals that they will mention something to their physician, and doctor will say, "Oh, Dr. Google told you that, and I'm the physician here," type of a thing. So could you give some concrete examples of how to self-advocate? Because I think, especially, well, with most diseases, that's very, very important, but I think that'd be very, very helpful if you both can contribute. Thanks.
Sure, I can give some examples. I have some patients that come in, they've written down their symptoms of concern, and they come in when I sit down, they're like, okay, these are my concerning symptoms, and they kind of go through everything. I'm very open to the patient talking about all of their symptoms because as we see, there are some disease processes that affect many different body systems. So I don't stop my patients and just say, only talk to me about your cardiac symptoms. So I'm very open to them going through their list of symptoms of concern, and then we start addressing them and talking about them and figuring out a good plan of care together. So I definitely do think it helps when patients have written things down because oftentimes they may get into the office and maybe kind of get sidetracked in their mind, and then they end up leaving the office and they're like, oh, I wanted to ask that question. So writing down your symptoms, and then also you and your healthcare provider are a team for you. So you have to be an active member of that team as well. And don't shy away from being an active member of that team. You have to be your best advocate. Yes, the healthcare providers are going to be looking for certain things and using their expertise, but working together as a team, I think, has the best outcomes. So don't be afraid to advocate for yourself, to talk, and then kind of write down your symptoms and questions as well. If you're specifically concerned about cardiac amyloidosis, I would specifically write down cardiac amyloidosis as well. Hey, I was listening to this on the radio, and these are the symptoms that I'm concerned about based on this. I think the more information you give your medical provider, the better.
Yes, and I would agree with that. It is also is very important who your provider is now. Dr. White is a nurse provider, advanced practice nurse. And the record shows that nurses tend to listen more and they and that's important because I wish I could tell you that you could go. You could go to a physician's office tomorrow and tell them you got all these symptoms, and you may or may not be heard even today. Because I can tell you, I have a cardiologist. I know more about this than he does. Because he says, let me tell you what he says, kind of like he pat you on the head. Now, the only reason I stay with him is because I know. If I didn't know, I wouldn't go to him because he knows I have all this history of all these things, and he just writes them down. He doesn't say, well, how are you doing? Did you? I tell all my siblings had this. He does. He's never asked me were you tested, and that's the so it's not. It's my point is it's not easy. You have to seek and you have to keep on, and we have to help people. Not all people as comfortable as some of us are in terms of advocating and speaking up, because we were kind of taught that the doctor knows it all, so you just kind of sit there and okay, and then you leave not satisfied because you didn't get your question. So it's not that easy, even today, even knowing what I know, to go in and have someone who really listens. So I would just say you just have to keep trying and keep working. And sometimes it does mean changing. It means, maybe going to a medical center. And sometimes the best person you can talk to is a resident because they'll listen to you, a resident or intern. And they'll listen to you and advocate for you because they got to take all these notes and stuff. It's not easy, but we have to keep working on it.
I think that's why we have the commitment to do these town hall meetings and these health fairs. And again, through AstraZeneca and my company Woods and Roger over at Hopkins, because we get the best information when we come to these kind of forums like this. So again, we have to keep doing these forums as well as we have to keep attending them and keep bringing family members. My sister was at the last forum, the part one of this. And the next day she ran to her doctor. She took her whole list and she's still running through her test now, which you kind of know what that means, right? I'm next. Okay, so I've got to go get the same testing because I do suffer from some of the symptoms. I have some other health issues too, but the initial stage is a lot of what's on this paper. So again, these are the kind of forums where you can ask the questions and you can talk to clinicians up front. And hopefully when this is over, you will take the time to talk to our clinicians that are here with their busy schedules and really dig down and find out as much as you can find out so you can go to the doctor with some real questions to get some real answers. Right. We have a question in the back.
Real quick, what does the testing consist of?
Sure. Great question. So it's going to start with a blood and urine test. So then we can rule out a different type of amyloidosis, which is a light chain amyloidosis that's treated in a different way. And then typically speaking, so I should back up a little bit. First, your healthcare provider is going to review your history, review your symptoms, review all of the diagnostic tests that have already been done. So usually a patient comes to me already with an echocardiogram, which is the ultrasound of the heart, with an electrocardiogram, which is the electrical conduction as well, and then also some other blood tests. So if I'm concerned about cardiac amyloidosis based on the patient's family history, their symptoms, their past medical history as well, and the test findings that I already have, when I'm looking for cardiac amyloidosis, then we'll start with blood and urine tests to rule out the other type of amyloidosis, one of the other types of amyloidosis, light chain amyloidosis, which is treated differently. And then if that is negative, once we've ruled that out, then we'll typically, for most patients, proceed with a PYP scan. In order for, it's just a simple test, takes about 4 hours, and we're able to, bone scintigraphy is another term for it, non-invasive test, pretty straightforward. And that's able to give us a definitive diagnosis if positive to a certain point. If I'm looking for other things, the patient may have a cardiac MRI or a cardiac PET scan as well. In more rare cases, would a patient be sent for an endomyocardial biopsy? Typically, we use these non-invasive tests to help determine if the patient has cardiac amyloidosis.
That's after the genetic test,
And then, thank you. So you have two kind of routes. So if you have a family member that tested positive, then typically you'll start with kind of a genetic test, and then maybe you're like, I had a positive genetic test, and then you're seeing the cardiologist. So that's one route. Another route is if the patient is just coming from a symptom standpoint. So if it's just symptoms and there's not really any genetic testing that's been done, it's not until they have a diagnosis of transthyretin cardiac amyloidosis based on one of the other tests that I just discussed, then I'll do genetic testing after that point in time to determine if it's wild type or if it's hereditary. So yeah, genetic testing can either come before, depending on if one of their family members had it and that's why they were tested, or it typically comes after the workup and diagnosis.
Are there any other questions?
So we live in an area, or we are in an area right now with a lot of great medical centers. I think it's clinicaltrials.gov is kind of one of the good resources to kind of check out the different clinical trials. But there are a lot of medications being studied on the market right now. So I definitely would kind of take a look, see if they're still enrolling, what phase they're in, and also your big medical centers as well typically are running some clinical trials if you have a medical provider at one of those centers. But clinicaltrials.gov is kind of a good way to learn about different clinical trials going on in the area.
I have a question, and I think you both already addressed it, but if you could dive down a little bit deeper. How familiar are a lot of subspecialists, especially cardiologists, how familiar are they with this disease or condition? Is this something that gets diagnosed as something else because of those symptoms? Could you clarify that?
There's growth that needs to be done in that area, and I think that that's why we're doing these not only educational events with the community, but from a professional standpoint as well, having a lot of these educational events at different conferences, and even kind of having kind of a lot of virtual educational sessions as well, so medical providers can learn more about it. So I will say, don't depend solely on your medical provider being super familiar with cardiac amyloidosis. There is some advocating that needs to occur, but I would recommend trying to get in with a specialist, cardiologist, a heart failure specialist, or depending on what's going on, sometimes an advanced heart failure specialist as well. But to answer your question, Arnie, I think there's a lot of room for growth.
I would agree with that. Don't count on it. You would be, but I would also say, if you're going to a cardiologist, a primary care person, try to get you an appointment, which is in some of the insurance plans, you really can't do this, but if you can get an appointment where they have an advanced heart failure center, and sometimes you need a referral to get there, but most of the time, you really have to push, because it is not the first thing. Because remember, congestive heart failure is very common. A whole lot of folk walking around with congestive heart failure. So if you go to a cardiologist and you got congestive heart failure, you got congestive heart failure, and there's certain ways that they treat it. They're not, the first thing they think about is not going to be, let's see if this person has cardiac amyloidosis.
So going off of what you just said, Ms. Velma, because we know that congestive heart failure kind of mimics this, and also diabetes in combination can present all of these symptoms. And you saying, go to an advanced heart failure clinic. And I guess my question would be, at what point do you really push past that point? What is it that we could look for? Because I know, Jannae, you had mentioned, the testing and everything. But if you have a doctor that's not really advocating or, saying, well, you just got congestive heart failure, or, people with diabetes have neuropathy, you're going to have the numbness and tingling. At what point would you advocate for a person and say, well, you really should go and get further testing done?
If you don't feel like your concerns are being addressed, I would say. So sometimes we can't reverse the symptom that somebody is experiencing, But as a medical provider, it's your job to talk to the patient and help them have an understanding of why we're doing what we're doing, why we don't suspect this in your case, or why there may be some concern and and why we may need to do some additional testing. I don't think that you should send everybody for all of these medical tests. I think that will crowd up the medical system and the testing, and those patients that really need it won't be able to get an appointment for months to get the testing that they need. So your medical providers do need to screen individuals appropriately. But I think that as a medical provider, you also need to be talking to your patients about, hey, this is why I don't think we need to be concerned about this, or in this case, this is why I think we should do some additional testing. So if you don't feel like you're satisfactorily have a good understanding with that, find a different medical provider.
Dr. White, if you could just leave
Let
us.
me just add also, look at the family history. If you have someone who's, and you're right, so much of the stuff that we have, Dr. White talked about that, how it mimics other things. But if you have a family history, someone says, well, my mom died with heart failure, my brother has it. That's a clue right there. Well, then maybe we need to look a little further, because probably the person has had echocardiograms, has had all that stuff. So the thing they need now is that genetic test. But see, if you're not positive for that defective gene, you can't have cardiac amyloidosis. See? So that's probably the only thing that they need at that point. So look at the family history. And sometimes they do have that history that all of their siblings died with heart failure. In the country they used to call it heart dropsies. Mama died with heart dropsies. That expression.
Yeah.
So look at the history.
Thank you. And just to piggyback off of that, the genetic testing will tell you if or if not you have hereditary cardiac amyloidosis. It won't necessarily tell you if you have wild type, but it will tell you if you have hereditary or not.
Wayne, you see me.
All right,
I see
see
you
you.
looking at me.
I'm looking right at you.
Which symptoms tend to come first in the patients, or Miss Velma with your family members, or Jannae? Do you see peripheral neuropathy or carpal tunnel first, or is there a normal timeline, and if so, which ones do you think come first in your experience?
Do you want to speak to your experience first, Ms. Velma, and then I'll follow up on it?
It varies, because with my sister, one of them, her first symptom was she had a stroke. She's in atrial field. She thinks she's okay, because remember, she actually worked where she remember they used to do word processing. You all remember that? So she actually had carpal tunnel, but a lot of folk who did that had carpal tunnel. So no one associated that with amyloidosis. So it varies. Hers started with carpal tunnel, then the next thing you know, she had a stroke. They said, oh, she's in atrial field. We didn't know that because she had the stroke. Whereas with my brother, it was the neuropathy. My feet hurt, and it was the joint, because the joints tend to basically just wear out from these protein deposits. So he had that hip replacement very early. So those were the early things with him. And then the other sister, the same thing, atrial field and a stroke. But she had been for at least 2 years complaining of nerve pain, severe nerve pain. No one related these symptoms. So it varies with the person.
I do agree that it varies as well. Typically, all of my patients come to me with heart failure. So I'm seeing them pretty late in their disease process. Typically, they've already had musculoskeletal joint symptoms, and they've already had nerve symptoms with the numbness and tingling, and maybe have a carpal tunnel release. So typically they're coming to me with their ongoing heart failure symptoms now, but in their history, they've been having or already had these neurologic and musculoskeletal symptoms. But it does really vary.
Thank you.
Yes.
if your primary care or your nurse practitioner is not listening to you, you need to leave. And before you reschedule an appointment, look at the reviews on Google. That will give you a lot of information because not everybody is in alignment with listening. And we know, being people of color and some of us women, they don't listen at all. Just like you said, they just patting you on the head and be like, hey, how you doing? Right, I'll see you later. Bye. No, wait a minute. The other thing you can use is my chart. If your appointment is 3 to 6 weeks out and you're nervous about speaking, put those questions in there. If you're like, I'm not good at writing things, put your questions in Chat GPT, copy and paste it, and say, I want these questions in a short form for my doctor because I know my doctor's busy. And it will give you that, and you can put that in my chart in your message. Make sure they have your medical records before you get there, especially if your appointment is 3 to 6 weeks out, so they can have time to look at your records and your family history. And if you need an advocate, I got you.
Let's give her a seat up here. Some good information. Thank you.
So Dr. White, if you could just give us 5 key takeaways
Ah.
in this program.
Absolutely. Thank you all for coming. I think that number one, my friend here said it best, be your own best advocate. Number one or number two, know your body. Listen to your body as well. Kind of pay attention to what feels right, what doesn't feel right, what's different, what's been changing. That way you can work with your medical provider to best assess what's going on and come up with a great treatment plan for you. And educate yourselves as well. Continue to learn more and teach those around you as well.
Thank you, Dr. White. Thank you very much. I mean, before we end on this conversation, all the actions. Sitting on the front row. Yes. Andrea, thank you for your call to action, because that's exactly what we have to do, is a call to action. And we must talk to our doctor if someone you know is experiencing these symptoms that we've discussed tonight. hATTR is a progressive disease, and so it's important to get diagnosed, as we heard earlier from Ms. Velma and from Dr. White, that we get treatment early, as soon as possible. As in any disease, the earlier we do it, the better off it is. And you should let your family know if your amyloidosis is due to gene mutation. Of course, I'm waiting for my sister's final results, so I know whether I have to go through these tests, but most likely I will, because my mother's also showing some symptoms of it also. So again, we're not afraid, and we're not going to be afraid, because we are educated folks, and hopefully more educated this evening. But the main thing is, if there's any doubt, we have a great survey that he is handing out to you. It's called Listen to Your Body. AstraZeneca is a fantastic piece. I've looked at it. It's been on my kitchen table for a couple of weeks, and it does answer your questions. It does kind of give you insight to what you should be asking, and it's a great tool to take with you to the doctor. Take it with you. Don't try to memorize it. Don't try to, oh, I left it in the car. It's a great tool to take with you when you go to see your doctor. It's kind of a self-assessment. As you heard our panel say earlier, nobody knows yourself better than you know yourself. So again, I would definitely invite you that you use that. So in closing, this is a great resource. Hopefully you use it. Again, on behalf of AstraZeneca, Woods Adult Daycare, Ms. Velma, who is our resident, tell it like it is, okay? She's gone through it. She knows what it is. It's real, as well as Dr. White, who sees this condition every day. So we have 2 great advocates in the room. So please take the time to stop them after we close the program. You may not be able to talk to them all night, but you may be able to get a follow-up or get some questions answered by talking to them. But overall, you guys have been a great audience. You guys have been fantastic as usual. And again, I just want you to give them a round of applause for being a great panel again. And again, thank you so much for making them fun. We go to these forums all the time, and they're not very informative, are they? Kind of a waste of our time. But I think we got a lot of information out of this. Wouldn't you agree? Okay, so again, thank you, everyone. Get home safely. And again, thank you very much for attending this town hall on hATTR. And thank you so much for coming out. Good night.